Good day. I am Dr. Gerald Bermudez and I am a practicing endocrinologist. I am from the Department of Medicine and for today I will be lecturing to you disorders of the adrenal cortex as well as disorders of the adrenal medulla. The lecture is primarily based on our textbook, Harrison's Principle of Internal Medicine 20th edition. Let's begin the lecture by reviewing first the adrenal anatomy, its function, as well as its development. We all know in anatomy that the adrenal glands are tiny glands located above the kidneys and they have their own blood supply. Normally, the adrenal glands weigh around 6 to 11 grams each. In histology, we also have learned that the adrenal cortex is formed by three layers known as the zona glomerulosa, the zona fasciculata, as well as the zona reticularis. Now, the blood supply of this layer courses initially to the subscapular region, going from the outer cortical zona glomerulosa through the intermediate zona fasciculata to the inner zona reticularis and eventually to the adrenal medulla. We also have learned in anatomy that the right suprarenal vein drains directly into the inferior vena cava while the left suprarenal vein drains into the left renal vein. During the early embryonic development, the adrenals originate from the urogenital ridge and then separate from the gonads and kidneys at about the 6-week age of gestation. Concordant with the time of sexual development or sexual differentiation, that's around 7 to 9 weeks age of gestation, the adrenal cortex starts to produce cortisol and the adrenal sex steroid precursor DHEA or dehydroepiandrosterone. Now, several nuclear factors are also important in this period of development. We have the orphan nuclear receptor SF1 or steroidogenic factor 1 as well as the DAX1 gene, also known as the dosage sensitive sex reversal gene 1. These two genes basically play important functions during this development because they regulate a multitude of adrenal genes which is involved in steroid production. An example of that, if there is an SF1 mutation, which may result in an increase of this gene, it may cause adrenal overactivity, and a deficiency in this gene would cause gonadal failure or 46XY DSD or disorder of sex development. On the other hand, if there is a mutation in DAX1 gene, it produces the disease so-called adrenal hyperplasia congenita, which consists adrenal insufficiency and hypogonadotrophic hypogonadism. I have mentioned a while ago the three layers of the adrenal cortex, and these produce also the three classes of corticosteroid hormones, namely glucocorticoids, which is basically, the most common example is cortisol, mineralocorticoids. An example of that is aldosterone and adrenal androgen precursors. I have mentioned about DHEA or dehydroepiandrosterone. Glucocorticoids and mineralocorticoids act through specific nuclear receptors, which regulates several aspects of physiologic stress responses, as well as blood pressure and electrolyte homeostasis. And the most important ones would be the sodium and potassium homeostasis. Adrenal androgen precursors are converted in the gonads and peripheral target cells to sex steroids that act via nuclear androgen and estrogen receptors. Now let us discuss the regulatory control of steroidogenesis. Production of glucocorticoids and adrenal androgens is under the control of the hypothalamic pituitary adrenal axis or HPA axis, whereas mineralocorticoids are regulated by the Renin-Angiotensin-Aldosterone system or RAAS. Glucocorticoid synthesis is under the inhibitory feedback control by the hypothalamus and the pituitary gland, as you can see in the leftmost portion of the slide. Hypothalamic release of corticotropin-releasing hormone, or CRH, occurs in response to endogenous or exogenous stress, or even any form of stress, such as physical, mental, or emotional stress, or under several conditions such as fever, hypoglycemia, or even hypotension. CRH stimulates the cleavage of POMC or pro-opiomelanocortin by pituitary-specific prohormone convertase 1 enzyme, eventually yielding a 39 amino acid peptide, ACTH, or adrenocorticotropic hormone. ACTH is primarily released by corticotrope cells of the anterior pituitary and then acting eventually as the pivotal regulator of adrenal cortisol synthesis, with additional short-term effects on mineralocorticoid and adrenal androgen synthesis. The release of CRH and subsequently ACTH occurs in a pulsatile fashion that follows a circadian rhythm under the control of the hypothalamus, specifically its suprachiasmatic nucleus, with additional regulation by a complex network of spell-specific clock genes. As you can see in the illustration below, reflecting the pattern of ACTH secretion, adrenal cortisol secretion exhibits a distinct circadian rhythm, starting to rise in the early morning hours prior to awakening, with peak levels in the morning around 8 to 9 a.m. and low levels in the evening. This is very important in getting samples for cortisol testing as well as its interpretation. For example, if a patient exhibits a very high cortisol at midnight, this patient could have hypercorticolism because again, under physiologic condition, cortisol should be low at this time. Diagnostic test assessing the HPA axis makes use of the fact that it is regulated by the negative feedback mechanism. Glucocorticoid excess is diagnosed by employing a dexamethasone suppression test. Dexamethasone is a potent synthetic steroid which inhibits production of CRH. If cortisol production is autonomous, let's say for example in patients with adrenal Cushing's, ACTH is already suppressed and dexamethasone has little additional effect. If cortisol production is driven by an ACTH-producing pituitary adenoma, dexamethasone suppression is ineffective at low doses but usually induces suppression at high doses. We call this in endocrinology low-dose dexamethasone suppression test or high-dose dexamethasone suppression test. If cortisol, on the other hand, is driven by an ectopic source of ACTH, let's say for example in paraneoplastic syndromes, the tumors are usually resistant to dexamethasone suppression. Thus, dexamethasone suppression test is useful to establish the diagnosis of Cushing syndrome and to assess with the differential diagnosis of cortisol excess. Now, to assess glucocorticoid deficiency, ACTH stimulation of cortisol production is used. Administration of ACTH must produce in normal individuals a cortisol level of more than 550 nanomoles per liter, and below this value, these individuals are said to be cortisol deficient or insufficient. Alternatively, an insulin tolerance test or ITT can also be used to assess adrenal function. This involves injection of insulin to induce hypoglycemia, which represents a strong stress signal that triggers hypothalamic CRH release and activation of the entire HPA axis, as we have mentioned a while ago. ITT also assesses growth hormone axis, and normally, a normal result is that growth hormone would induce production of more than 5.1 micrograms per liter. Now, the insulin tolerance test is contraindicated in patients with seizure disorders or in patients with coronary artery disease or cerebrovascular diseases, as hypoglycemia may aggravate these conditions. On the other hand, mineralocorticoid production is controlled by the RAA regulatory cycle, which is initiated by the release of renin from the kidneys, resulting in cleavage of angiotensinogen to angiotensin 1, which occurs in the liver. Angiotensin converting enzyme or ACE cleaves angiotensin 1 to angiotensin 2, which binds and activates the angiotensin 2 receptor type 1, which eventually result in an increased production of adrenal aldosterone and hence vasoconstriction. Aldosterone in turn enhances sodium retention and potassium excretion and eventually increases the arterial perfusion pressure, which in turn regulates renin release. Because mineralocorticoid synthesis is primarily under the control of the renin-angiotensin-aldosterone system, hypothalamic pituitary damage does not significantly impact the capacity of the adrenals to synthesize aldosterone. And similar to the HPA axis, the assessment of the RAAS can be used for diagnostic purposes. And for example, if mineralocorticoid excess is present, there is a counter-regulatory downregulation of plasma renin. And conversely, if there is a deficiency of mineralocorticoid, plasma renin is markedly increased. Under physiologic condition, an oral or intravenous sodium loading results in suppression of aldosterone, a response which is absent in patients with autonomous mineralocorticoid excess. Also, this system forms the basis of antihypertensive medications under the classifications of ACE inhibitors and ARB to decrease blood pressure. If, for example, you give lisinopril, an ACE inhibitor, angiotensin 1 will not be converted to angiotensin 2, and therefore the cascade does not continue. As a result, there is no increase in aldosterone, there is no vasoconstriction, hence blood pressure decreases. Same thing happens with ARB except that it works on the receptors. Just like in biochemistry, we cannot escape the steroidogenic pathway when we discuss diseases of the adrenal cortex, and you have to be familiar with this. Three main types of hormones are produced by the adrenal cortex, namely glucocorticoids, which are mainly cortisol and corticosterone, mineralocorticoids, mainly aldosterone and deoxycorticosterone, and your sex steroids, mainly androgens. Secretion of steroids are layer specific. Remember the histology of the adrenal cortex. Glucocorticoids are secreted in relatively high amounts from the zona fasciculata under the control of ACTH, while mineralocorticoids are secreted in low amounts from the zona glomerulosa under the principal control of angiotensin 2. On the other hand, as a class, adrenal androgens coming from the zona reticularis are the most abundant steroids secreted from the adrenal gland. Cholesterol is the precursor of adrenal steroidogenesis. It is provided principally from the circulation in the form of low-density lipoprotein cholesterol. The biochemical pathways involved in adrenal steroidogenesis are shown in the picture. The initial hormone-dependent, rate-limiting step is the transport of intracellular cholesterol from the outer to inner mitochondrial membrane for conversion to pregnenolone by cytochrome P450 side chain cleavage enzyme. Progesterone is hydroxylated to 17-hydroxyprogesterone through the 17-alpha hydroxylase activity of CYP17A1. 17-alpha hydroxylation is an essential prerequisite for glucocorticoid synthesis, and the zona glomerulosa does not express 17-alpha hydroxylase. CYP17A1 also possesses 1720 lyase activity, which results in production of the C19 adrenal androgen, DHEA, and androstenedione. To understand further the effect of ACTH on steroidogenesis, let us discuss the hormone and receptor interaction. The ACTH receptor, known as melanocortin-2 receptor, interacts with its accessory protein MRAP, and the complex is transported to the adrenocortical cell membrane, where it binds to ACTH. ACTH stimulation generates cyclic AMP, which eventually upregulates the protein kinase A signaling pathway. When this is activated, there is entry of cholesterol into the cytosol and eventually into the mitochondrion to start the steroidogenic pathway. Now, once a certain steroid is produced, in this case, a glucocorticoid, it will bind and activate the glucocorticoid receptor or the GR, which eventually results in dissociation of heat shock proteins from the receptor and subsequent dimerization. Cortisol-bound glucocorticoid receptor dimers eventually translocate to the nucleus and activate certain glucocorticoid response elements in the DNA sequence, thereby enhancing transcription of glucocorticoid-regulated genes. You can see here that cortisol and aldosterone bind the mineralocorticoid receptor or MR with equal affinity. However, cortisol circulates in the bloodstream at about 1,000-fold higher concentration. Thus, only rapid inactivation of cortisol to cortisone by 11 beta hydroxysteroid dehydrogenase type 2 prevents MR activation by excess cortisol. You will learn later that a certain disease happens if cortisol will activate your MR. And therefore, under normal physiologic condition, aldosterone will be the one interacting with the MR. Just like cortisol, action on its receptor in the kidneys, as you can see in the illustration, this is the principal cell of the kidney. Aldosterone dissociate heat shock proteins. Activation of MR enhances transcription of the epithelial sodium channels, ENaC, and serum glucocorticoid inducible kinase 1, mediating sodium reabsorption and retention. We have discussed the biochemistry and physiology of the adrenal cortex, and understanding this will help us further understand the pathologic mechanisms of diseases of the adrenal cortex. In endocrinology, abnormalities are apparent if there is hormone hypersecretion or hyposecretion, or in cases wherein there is enough hormone but it does not function or bind to its receptor, and we call these hormone resistance syndromes, which clinically manifest as hormone deficiencies. Let us discuss hypersecretion syndromes of the adrenal cortex. The first one is Cushing's syndrome. Cushing's syndrome comprises the symptoms and signs associated with prolonged exposure to inappropriately elevated levels of free plasma glucocorticoids of any etiology, be it pituitary or adrenal Cushing's, or the rarer ectopic tumors producing ACTH or cortisol. The incidence of Cushing syndrome is about 1 to 2 per 100,000 population per year. The most common cause of Cushing syndrome is actually exogenous steroid use. There are several causes of Cushing syndrome, depending on the classification and excluding exogenous steroid use. The most common cause is Cushing's disease, pituitary origin. Now, in patients with ACTH-independent Cushing's, they usually harbor adrenocortical adenoma. Cushing syndrome affects more commonly women than men, but except in the prepubertal cases, boys are more commonly affected than girls. On the other hand, ectopic ACTH syndrome more commonly affects men than women. 90% of Cushing syndrome is primarily caused by a corticotropic microadenoma or a pituitary adenoma. And this has mutations in the ubiquitinase USP8, which activates epidermal growth factor signaling, upregulating expression of the ACTH precursor POMC. Most of these cases are sporadic, but they can be a part of MEN1 or multiple endocrine neoplasia type 1. Remember the three P's of MEN1: pituitary, parathyroid, and pancreatic tumors. Now, in cases of ectopic ACTH, most of them are found in cases with carcinoid tumors or paraneoplastic syndromes, most commonly small lung cell carcinoma. Ectopic ACTH syndrome parallels that of bronchogenic carcinoma, and although 0.5% of lung cancer patients have ectopic ACTH syndrome, rapid progression of the underlying disease often precludes an early diagnosis. Aside from multiple endocrine neoplasia, Cushing syndrome may also be a feature of Carney's complex and McCune-Albright syndrome. The classic features of Cushing syndrome, centripetal obesity, moon phasie, hirsutism, and plethora have been well known over a century now. However, this gross clinical picture is not always present, and a high index of suspicion is required in many cases. They are summarized in the table in the slide together with the most discriminatory features that will assist us in distinguishing Cushing syndrome from simple obesity. Most discriminatory features include thin and brittle skin, easy bruising, purple stretch marks, and proximal myopathy. The most important first step in the management of patients with suspected Cushing syndrome is to establish the correct diagnosis. In principle, after excluding exogenous glucocorticoid use as the cause of clinical signs and symptoms, suspected cases should be tested if there are multiple and progressive features of Cushing's, particularly features with a potentially higher discriminatory value, which I described a while ago. A diagnosis of Cushing's can be considered as established if the results of several tests are consistently suggestive of Cushing syndrome. Now, there are several screening tests to be used. We can use either the 24-hour urinary free cortisol excretion, in which we expect an increase value above the normal by threefold if there is Cushing's, or we can also use dexamethasone overnight testing in which we expect a result of plasma cortisol above 50 nanomole per liter at 8 to 9 a.m. after 1 milligram dexamethasone at 11 p.m. Or also we can use midnight plasma cortisol. A result of more than 130 nanomole per liter is also suggestive of Cushing syndrome. If further confirmation is needed, we can also use low-dose dexamethasone suppression tests. Now, if the results are negative, then no further testing is required. We have to establish 2 out of the 4 or 5 testing on the screening to establish a patient with Cushing syndrome. Now, if this is positive, then we have to test further this patient in order for us to narrow down our differential diagnosis. To proceed, we have to test for plasma ACTH. Now, a normal ACTH or high ACTH that's above 15 picograms per ml, then this might be a patient with ACTH-dependent Cushing syndrome. And the most common cause of this one is Cushing's disease or pituitary Cushing's. However, if ACTH is suppressed to a value of less than 5 picograms per ml, then we suspect a case of ACTH-independent Cushing's disease or Cushing syndrome. I have mentioned that most of these patients will harbor an adrenocortical adenoma. Having confirmed Cushing syndrome clinically and biochemically, the clinician's next step is to determine the cause. Now, going back with our ACTH, if ACTH is normal or is elevated, we might be dealing a case of ACTH-dependent Cushing's. Having known that the most common cause of ACTH-dependent Cushing's is Cushing's disease or pituitary Cushing's, we have to request this patient with MRI of the pituitary. Other testing which may be needed includes CRH testing or high-dose dexamethasone testing. Now, if CRH test and high-dose dexamethasone test is positive, then this is a case of Cushing's disease, and we have to refer this patient for transsphenoidal pituitary surgery. On the other hand, if CRH test and high-dose dexamethasone is negative, then we might be dealing a case of an ectopic ACTH production. If this is so, we have to do further testing. And if the tests are equivocal, we also have to do some further testing. We do the inferior petrosal sinus sampling. This is the most robust test to distinguish Cushing's disease from the ectopic ACTH syndrome, because blood from each half of the pituitary drains into the ipsilateral inferior petrosal sinus. Catheterization and venous sampling of both sinuses simultaneously can distinguish a pituitary from an ectopic source of ACTH. Now, in virtually all patients with the ectopic ACTH syndrome, the ratio of the ACTH concentration in the inferior petrosal sinus and that in simultaneously drawn peripheral venous blood is less than 1.4 is to 1. In contrast, the ratio is elevated to greater than 2 in Cushing's disease. And if this is positive, then we refer this patient for transsphenoidal pituitary surgery. However, if this is negative, we have to locate and remove the ectopic ACTH source. If we cannot see any source, then eventually we might do bilateral adrenalectomy in these patients. On the other hand, if ACTH is suppressed, then we might be dealing a case of ACTH independent Cushing's. And having known that the most common cause of ACTH independent Cushing's is adrenal adenoma, we request this patient with an enhanced CT scan of the adrenals. If we see hyperplasia of both adrenal glands, we refer this patient for bilateral adrenalectomy. If only a unilateral adrenal mass is seen on the CT scan, we also do some further adrenal tumor workup. And if this patient are candidates for surgery, then we refer this patient for unilateral adrenalectomy. This is a transverse cut section of a whole abdominal CT scan adrenal protocol. Arrows in plates A and C illustrates normal adrenal glands, while arrows in plates B and D illustrates an adenoma, which are usually well demarcated, round or oval, with homogeneous and relatively low attenuation values due to high fat content. This is an example of an MRI of the pituitary gland. Your left side is a sagittal section. On your right side, there is a transverse cut section. The pictures located above is the normal pituitary gland, which actually shows a marked homogeneous enhancement. And on a transverse cut, there is no deviation of the pituitary stalk. On the other hand, the pictures below shows an abnormality of the pituitary gland. You can see there a small nodular lesion occupying the whole of the sellar area. And on the fusion weighted image, you can see there that the lesion is hyperintense compared to the normal brain parenchyma, which is a characteristic of a pituitary adenoma. For the management, basically, patients with Cushing's disease should be referred for transsphenoidal excision of mass, giving a 70 to 80% cure rate. In cases where the disease is recurrent, a second surgery should be considered, or if not, radiotherapy can be done or stereotactic surgery. In worst scenario, bilateral adrenalectomy may be considered, but this is rarely done today. In patients who are not candidate for surgery, medical therapy may be given to them. Post-surgery, you have to remember that the hypothalamic pituitary adrenal axis may require many months or even years to resume normal function and sometimes does not recover. And so this patient may require steroid replacement therapy. This illustration shows you some of the most common drugs employed in the medical management of hypercorticolism and the enzymes they block in the steroidogenic pathway. Metirapone inhibits cortisol synthesis at the level of the 11-beta hydroxylase, whereas the antimycotic drug ketoconazole inhibits the early steps of steroidogenesis. Mitotane is an adrenolytic drug which is also effective for reducing cortisol level. Hypertension, suppressed plasma renin activity, and increased aldosterone excretion characterize the syndrome of primary aldosteronism, which was first described in 1955. Aldosterone-producing adenoma and bilateral idiopathic hyperaldosteronism are the most common subtypes of primary aldosteronism. Somatic mutations account for about half of aldosterone-producing adenoma, and these mutations are responsible for increasing sodium and calcium influx in the zona glomerulosa. Bilateral micronodular hyperplasia is more common than unilateral adrenal adenoma. A rare cause of aldosterone excess is glucocorticoid remediable aldosteronism or GRA, which is caused by a chimeric gene resulting in mutation in CYP11B1 and CYP11B2, which are involved in glucocorticoid and mineralocorticoid synthesis respectively. This causes aldosterone production regulated by ACTH rather than by renin. Another important cause is an excess binding of MR by a steroid rather than aldosterone. Remember that cortisol and aldosterone are potent activator of MR. However, cortisol is rapidly inactivated to cortisone. Thus, only aldosterone must activate the MR. There are two types of this disease. Type 1 causes severe hypokalemic hypertension in childhood, and type 2 causes normokalemic hypertension. This table shows you the different causes of mineralocorticoid excess and their pathologic mechanisms. Again, the most common cause of primary aldosteronism is an aldosterone-producing adenoma or Conn's disease. The diagnosis of primary aldosteronism is usually made in patients who are in the third to sixth decades of life. Few symptoms are specific to the syndrome. MR activation leads to potassium depletion and increased sodium retention. Patients with marked hypokalemia may have muscle weakness and cramping, headaches, palpitations, polydipsia, polyuria, nocturia, or a combination of this. There is also metabolic alkalosis due to potassium depletion by epithelial sodium channel activity. The clinical hallmark of mineralocorticoid excess is hypokalemic hypertension. Serum sodium tends to be normal due to the current fluid retention, which in some cases can lead to peripheral edema. A significant proportion of patients suffer from concurrent mild autonomous cortisol excess termed as Cushing's syndrome. Diagnostic screening for mineralocorticoid excess is not currently recommended for all patients with hypertension but should be restricted to those who exhibit hypertension associated with drug resistance, hypokalemia, and adrenal mass or onset of disease before the age of 40 years. The accepted screening test is concurrent measurement of plasma renin and aldosterone with subsequent calculation of the aldosterone-renin ratio. Serum potassium needs to be normalized prior to testing. MR antagonists such as spironolactone need to be ceased at least 4 weeks prior to ARR measurement. The remaining antihypertensive drugs usually do not affect the outcome of ARR testing. An ARR of more than 750 with aldosterone levels of more than 450 picomoles per liter usually indicates MR exists, and this needs to undergo confirmatory testing. The most straightforward is the saline infusion test, which involves the IV administration of 2 liters normal saline over a 4-hour period, and failure of aldosterone to suppress less than 140 picomoles per liter is indicative of autonomous MR excess. Alternative tests includes oral sodium loading test or the fludrocortisone suppression test. Now, in patients with overt hypokalemic hypertension, strongly positive ARR, and concurrently increased aldosterone levels, confirmatory testing is usually not necessary. After the diagnosis of hyperaldosteronism is established, the next step is to use adrenal imaging to further assess the cause. The differentiation between bilateral micronodular hyperplasia and a unilateral adenoma is only required if a surgical approach is feasible and desired. Consequently, selective adrenal vein sampling should only be carried out in surgical candidates with either no obvious lesion on CT or evidence of a unilateral lesion in patients more than 40 years old, because the latter patients have a high likelihood of harboring a coincidental endocrine inactive adrenal adenoma. Adrenal vein sampling is a criterion standard test to distinguish between unilateral and bilateral disease in patients with primary aldosteronism. Lateralization is confirmed by an aldosterone cortisol ratio that is at least twofold higher on one side than the other. Patients more than 40 years old with confirmed MR exists and a unilateral lesion on CT can go straight to surgery, which is also indicated in patients with confirmed lateralization documented by a valid AVS procedure. Patients who are not surgical candidates or with evidence of bilateral hyperplasia based on CT or AVS should be treated medically. In patients with normal adrenal morphology and family history of early onset severe hypertension, a diagnosis of glucocorticoid remeasurable aldosteronism should be considered and can be evaluated using genetic testing. Treatment of GRA consists of administering dexamethasone using the lowest dose possible to control blood pressure. On the other hand, the diagnosis of non-aldosterone related mineralocorticoid excess is based on documentation of a suppressed renin and a suppressed aldosterone in the presence of hypokalemic hypertension. Testing of 24-hour urinary steroid profile is employed in these patients. This table shows you the effects of antihypertensive drugs on the aldosterone-renin ratio. I have mentioned a while ago that among the classes of antihypertensive medication, the most important class of drugs to be stopped prior to testing are the MR antagonists. Examples are spironolactone and eplerenone. It may be difficult to interpret data obtained from patients treated with this type of drugs. These drugs prevent aldosterone from activating the receptor, resulting sequentially in sodium loss, a decrease in plasma volume, and an elevation in plasma renin activity, which will reduce the utility of the plasma aldosterone concentration, plasma renin activity ratio. For this reason, spironolactone and eplerenone should not be initiated until the evaluation is completed and the final decisions about treatment are made. Incidentally discovered adrenal masses, commonly termed adrenal incidentalomas, are common, with a prevalence of 2 to 5% in the general population as documented in CT scan and autopsy series. Majority are endocrine inactive adrenocortical adenoma but can be a feature of an endocrine neoplasm. 25% are hormonally active, either secreting cortisol, aldosterone, or catecholamine producing lesion or a combination of this. Adrenocortical carcinoma is rare but is the cause of an adrenal mass in 5% of patients. In the setting of a known primary tumor, an incidentally discovered adrenal mass may indicate metastasis. Now, in a patient with an incidentally discovered adrenal mass, two key questions need to be addressed. Does the tumor autonomously secrete hormones that could have a detrimental effect on health, or is the adrenal mass benign or malignant? Exclusion of catecholamine excess from a pheochromocytoma arising from the adrenal medulla is a mandatory part of the diagnostic workup. Furthermore, autonomous cortisol resulting in Cushing syndrome requires exclusion, and in patients with hypertension or low serum potassium, also primary aldosteronism. Now, if the mass is greater than 4 centimeters, serum 17-hydroxyprogesterone and dihydroepiandrosterone sulfate is also indicated. If the screening test is positive, confirmatory testing is necessary. Confirmatory testing is dependent on the type of hormone excess. If this is positive, then a unilateral adrenalectomy is indicated. If this is negative, then a repeat testing is advised after 1 year. Now, if the testing is negative but the imaging is suggestive of malignancy, a repeat imaging may be necessary and this patient may be advised eventually for surgery. Now, if the tests are negative and imaging are not suggestive of malignancy, then no further evaluation is needed in these patients. An enhanced CT is the procedure of choice for imaging the adrenal glands. A diagnosis of adrenocortical carcinoma, pheochromocytoma, and benign adrenal myelolipoma becomes more likely with increasing diameter of the adrenal mass. However, size alone is of poor predictive value with only 80% sensitivity and 60% specificity for the differentiation of benign from malignant masses. Imaging characteristics consistent with a benign cortical adenoma include round and homogeneous density, smooth contour with sharp margination, diameter usually less than 3 centimeters, unilateral location, low unenhanced CT attenuation values, usually less than 10 HU or Hausenfeld units, with rapid contrast medium washout at 10 minutes after administration of contrast medium. ISO intensity with liver on MRI sequences and chemical shift evidence of lipid on MRI. The imaging phenotype consistent with pheochromocytoma includes enhancement with intravenous contrast medium on CT, high signal intensity on T2 weighted MRI, cystic and hemorrhagic changes, and variable size. Also, the tumor may be bilateral. Adrenocortical carcinoma or ACC is a rare malignancy with an annual incidence of 1 to 2 per million population. ACC is generally considered a highly malignant tumor. Somatic mutations in the tumor suppressor gene TP53 are found in 25% of apparently sporadic ACC. Germline TP53 mutations are the cause of the Li-Fraumeni syndrome associated with multiple solid organ cancers including ACC. Fine needle aspiration is not indicated in this type of cancer because it does not differentiate between benign and malignant primary adrenal masses, and another is that aspiration biopsy violates the tumor capsule and may even cause tibial canal metastasis. The most common histopathologic classification is the Weiss score, taking into account high nuclear grade, mitotic rate of more than 5 per high power field, atypical mitosis, less than 25% clear cells, diffuse architecture, and presence of necrosis, venous invasion, and invasion of sinusoidal structures and tumor capsule. The presence of 3 or more elements suggests adrenocortical cancer. Mixed excess production of several corticosteroid classes by an adrenal tumor is generally indicative of malignancy. Excess production of glucocorticoids and adrenal androgen precursors are most common. The most common site of metastasis are the lungs and the liver. The most important prognostic histopathologic parameter of adrenocortical carcinoma is Ki-67 proliferation index. An index of more than 10% suggests poor prognosis, high risk of recurrence, or rapid progression. Cure of ACC can only be achieved by early detection and complete surgical removal. Patients with confirmed ACC and successful removal of the primary tumor should receive adjuvant treatment with mitotane. However, in cases of recurrence or progression on mitotane, chemotherapy with cisplatin, etoposide, or doxorubicin is indicated. However, despite treatment, the 5-year survival rate is around 30 to 40% only, and a median survival of 15 months in patients with metastatic ACC. At this point, we already have discussed adrenal hormone excess. Now we will be discussing adrenal deficiency or adrenal insufficiency. The prevalence of permanent adrenal insufficiency is 5 in 10,000 population, and the most frequent cause is hypothalamic pituitary origin. There are two types of adrenal insufficiency. The first one is primary adrenal insufficiency, which refers to glucocorticoid deficiency occurring in the setting of adrenal disease, and the most common cause is autoimmune adrenalitis. The second is secondary adrenal insufficiency or central hypoadrenalism, which arises because of a deficiency of ACTH, and the most common cause is iatrogenic suppression. A major distinction between these forms of adrenal insufficiency is that mineralocorticoid deficiency invariably accompanies primary AI, but this does not occur in secondary AI. Here, only ACTH is deficient and the Renin-Angiotensin-Aldosterone axis is intact. Secondary AI is also seen in the setting of Sheehan syndrome. This is a consequence of an infarcted pituitary adenoma or transient reduction in the blood supply of the pituitary rapid blood loss associated with parturition. This table shows us the different causes of primary adrenal insufficiency. The manifestations of adrenal insufficiency are varied. Patients with primary adrenal insufficiency usually have both glucocorticoid and mineralocorticoid deficiency. In contrast, those with secondary adrenal insufficiency have an intact RAA system. This accounts for differences in salt and water balance in the two groups of patients, which in turn result in different clinical presentations. The most obvious feature that differentiates primary from secondary hypoadrenalism is skin pigmentation, which is almost always present in cases of primary adrenal insufficiency. In secondary adrenal insufficiency due to hypopituitarism, the presentation may relate to deficiency of hormones other than ACTH, notably hypogonadism or hypothyroidism. Acute adrenal insufficiency, termed an adrenal crisis or Addisonian crisis, is a medical emergency manifesting as hypotension and acute circulatory failure. The diagnosis of adrenal insufficiency is established by the short cosintropin test, which is a safe and reliable tool with excellent predictive diagnostic value. The short cosintropin test or ACTH stimulation test involves intramuscular or intravenous administration of asynthetic ACTH. Plasma cortisol levels are measured at 0 and 30 minutes after ACTH administration, and a normal response is defined by a peak plasma cortisol level greater than 550 nanomoles per liter. The rationale of this test relies on the principle that the cortisol response to an exogenous bolus of ACTH is determined by the endogenous ACTH tropic drive to the adrenal cortex. Impaired ACTH secretion from the anterior pituitary results in an impaired cortisol response after synactin administration. If the diagnosis is confirmed, further testing is employed by measuring plasma ACTH, renin, and serum aldosterone. This is to differentiate whether the cause of adrenal insufficiency is primary or secondary in nature. If ACTH is high, renin is high with low aldosterone, this is consistent with primary adrenal insufficiency, and treatment includes glucocorticoid plus mineralocorticoid replacement. If ACTH is low to normal, renin is normal, and aldosterone is normal as well, this is secondary adrenal insufficiency, and treatment consists of glucocorticoid replacement. In primary adrenal insufficiency, adrenal autoantibodies are needed to further identify the cause of primary AI. If antibodies are present, then the cause of primary AI may be either autoimmune adrenalitis or autoimmune polyglandular syndrome. If antibodies are negative, then further testing may be necessary to identify other rarer cause of primary adrenal insufficiency. In cases of secondary AI, an MRI of the pituitary gland is necessary. If there is a lesion in the pituitary gland, then this might be the cause of the secondary adrenal insufficiency. However, if there are no lesions seen in the pituitary gland or in the sellar area, then other causes may include exogenous glucocorticoid treatment, or it could be secondary to head trauma, or we can consider isolated ACTH deficiency. Acute adrenal insufficiency is a life-threatening emergency, and treatment should not be delayed. In adults, initiation of hydration and intravenous hydrocortisone should be given in a dose of 100 milligrams every 6 to 8 hours, and this can be decreased to 50 milligrams every 6 hours after 24 hours. For long-term therapy, the aim is to give replacement doses of hydrocortisone to mimic the normal cortisol secretion rate, that is around 15 to 25 milligrams per day. Patients on glucocorticoid replacement therapy should be advised to double their daily dose in the event of intercurrent febrile illness, accident, or mental stress such as an important examination. This is called the stress dosing. In primary adrenal failure, Mineralocorticoid replacement is usually also required in the form of fludrocortisone. Although not routinely done, for patients with both primary and secondary adrenal failure, beneficial effects of adrenal androgen replacement therapy with 25 to 50 milligrams per day of dihydroepiandrosterone have also been reported. Congenital adrenal hyperplasia, or CAH, comprises a group of autosomal recessive disorders caused by deficient adrenal corticosteroid biosynthesis. It results from defects in one of the steroidogenic enzymes involved in cortisol biosynthesis or in the electron providing factor. The most common cause of CAH is 21 hydroxylase deficiency, and this has three classes, of which non-classical CAH is more common. An elevated 17-hydroxyprogesterone makes the diagnosis, and treatment includes glucocorticoid and mineralocorticoid replacement therapy. The condition arises because of defective conversion of 17-hydroxyprogesterone to 11-deoxycortisol. Reduced cortisol biosynthesis result in reduced negative feedback drive and increased ACTH secretion, and as a consequence, adrenal androgens are produced in excess. We have discussed diseases of the adrenal cortex. At this point, we will be discussing diseases of the adrenal medulla, specifically Pheochromocytoma, Paraganglioma. Pheochromocytomas and paragangliomas are catecholamine-producing tumors derived from the sympathetic or parasympathetic nervous system. These tumors may arise sporadically or be inherited as features of multiple endocrine neoplasia type 2, von Hippel-Lindau disease, or several other pheochromocytoma-associated syndromes. Catecholamine-secreting tumors are rare, with an annual incidence of 2 to 8 cases per 1 million people. Based on screening studies for secondary causes of hypertension in outpatients, the prevalence of pheochromocytoma has been estimated at 0.1% to 0.6%. Nevertheless, it is important to suspect, confirm, localize, and resect these tumors because, first, the associated hypertension is curable with surgical removal of the tumor. Second, a risk of lethal paroxysm exists. Third, at least 10% of the tumors are malignant. And fourth, 40% of these tumors are familial, and their detection in the proband may result in early diagnosis in other family members. Remember the classic rule of tens. These tumors are 10% bilateral, 10% extraadrenal, and 10% malignant. Catecholamine-secreting tumors that arise from chromaffin cells of the adrenal medulla and the sympathetic ganglia are referred to as pheochromocytomas and catecholamine-secreting paragangliomas respectively. Because the tumors have similar clinical presentations and are treated with similar approaches, many clinicians use the term pheochromocytoma to refer both adrenal pheochromocytomas and extraadrenal catecholamine-secreting paragangliomas. However, the distinction between pheochromocytoma and paraganglioma is an important one because of implications for associated neoplasms, risk for malignancy, and genetic testing. The clinical presentation of pheochromocytoma is so variable, ranging from an asymptomatic ones to very severe hypertensive crisis. Its dominant sign is hypertension, and among the presenting manifestations, episodes of palpitation, headache, and profuse sweating are typical, and these manifestations constitute a classic triad. The presence of all three manifestations in association with hypertension makes pheochromocytoma a likely diagnosis. The symptoms are caused by the pharmacologic effects of excess concentrations of circulating catecholamines. The diagnosis is based on documentation of catecholamine excess by biochemical testing and localization of the tumor by imaging. Elevated plasma and urinary levels of catecholamines and metanephrines form the cornerstone of diagnosis. MRI with gadolinium contrast is optimal for detecting pheochromocytomas, and CT scan is optimal or better for imaging extraadrenal pheochromocytomas and paragangliomas. On histopathology, Zell-Bolen pattern is evident, which consists of nests of neuroendocrine chief cells with peripheral glial-like sustentacular cells. Immunohistochemistry is positive for chromogranin and synaptophysin in the chief cells and S100 in the sustentacular cells. Treatment consists of complete tumor removal, which can be achieved by partial or total adrenalectomy. That ends my lecture regarding diseases of the adrenal cortex and adrenal medulla. Thank you for listening.